Good evening, everyone, and welcome to the webinar on the theme Treatment Landscape in First-Line Metastatic Breast Cancer. It gives me great pleasure to invite our chairperson, Dr. P.M. Mohapatra, Director of Medical Oncology, Apollo Cancer Center, Kolkata, to give the welcome address. Over to you, sir.
Good evening, everyone, and it's my pleasure actually to chair this session with a renowned international speaker. My is actually introduction and clinical context setting. Next slide, please. So we'll discuss now about the HER2 positive breast cancer. Actually, if you see the HER2 positive breast cancer, this is second most common breast cancer. Actually, when we diagnose breast cancer, we do only ISS actually, and one PIK3CA mutation you do actually it is more in metastatic setting, and in early setting its role is coming out. Actually, if you see the type of breast cancer, actually we see it is a HER2 positive, hormone positive, or triple negative. Still the ESMO guidelines actually holds true. Actually, it is actually either luminal A, these are hormone positive and low Ki67 HER2 negative. Luminal B, either it's a high Ki67 or HER2 positive actually, or ERPR negative HER2 positive negative actually. The 15 to 20%, we actually, what we see around 20% of our patients are HER2 positive. Next slide. So HER2 actually, when we started our post-graduation, when the HER2 actually trastuzumab came to India actually, HER2 is a receptor actually in the cell surface actually, which promotes the growth, survival and differentiation actually. If somebody HER2 is amplified actually, it promotes tumorigenesis. So HER2 actually is a bad prognostic for breast cancer till the HER2 directed therapy came actually. Otherwise, it's when we are actually trastuzumab very costly. We have never seen such good result with chemotherapy in HER2 positive breast cancer. Actually, it increases the metastasis, and main problem is around 50% of the patient can develop brain metastasis. Next slide. So NCCN actually, because of the recent trials, so the NCCN is also little changed actually. If the same actually Cleopatra trial, docetaxel, pertuzumab, taxane is there, but now actually the trastuzumab deruxtecan with pertuzumab actually came into picture actually, and actually because of Patina trial actually somebody is HER2 positive and hormone positive. 50% of the patient of HER2 positive may be positive for HR positive actually here palbociclib, pertuzumab, trastuzumab after you finish the taxane chemotherapy. So second line actually depends upon what you give in the first line. Actually, positive in or TDXT, but otherwise if there is no brain metastasis, TDXT is better actually. Then it's all third line is mainly physician choice, what you have not given in the first line or second line actually. Next slide. So what we are lacking actually, lack of any advancement after Cleopatra actually. Long back Cleopatra when we went to ESMO, the Cleopatra regimen came, and long gap after Cleopatra actually. Now actually there are Patina trial, there are Destiny 09 trial, there is Hard to Climb 5 trial actually. A lot of first line trials actually is come. We know actually the de novo metastasis fares better, and the recurrent HER2 positive metastasis, they don't fare better. They may be treated differently actually. So we'll listen and learn from this actually lecture actually. And bone marrow brain metastasis and visceral metastasis. The problem is actually brain metastasis. The first line treatments doesn't cover much about the brain metastasis. So brain recurrence are there actually. So we need a good first line treatment which will cover the metastasis actually. PIK3CA mutation actually 20% of the patient can have a PIK3CA mutation. If you give only trastuzumab, the PIK3CA patients, they don't do well. You don't get the good pathological CR if you give in a neoadjuvant setting. So these patients actually, you you must increase the treatment. PDXD may be a better treatment option in these cases, or you have to combine in future trial with typical PCA inhibitors actually. So HR negative, HER2 positive actually, which previously we thought it's hormone negative, HER2 positive. They are poor prognosis, but because of the HER2 directed therapy, this HR positive, HR negative, HER2 positive, they will do better. They do better with HER2 directed therapies. Next slide. So, what we need actually, because of the affinity trial, we know actually this only 2.7% actually improvement in 8 years data actually. The 25% patients still they recur actually. So you need a better treatment in a curative setting. So we know Destiny 05, I think that will also change the picture. Second line treatment actually, there were a lot of treatment, that is a Marian trial actually, TDM1 with pertuzumab. They compared with trastuzumab taxane actually, but it is never better than trastuzumab taxane actually. So the Cleopatra regimen remains free actually till now actually. And actually this Patina trial actually came in last San Antonio actually. This is actually, if you combine palbociclib in hormone positive patient, you are getting the PFS around more than 40 months actually. This is very good actually. So with palbociclib, so this patient, we know how to use palbociclib, and this patient, after you give treatment with taxane and actually trastuzumab, pertuzumab, you just combine with hormone therapy and palbociclib. Next slide. Thank you. Next slide. So we'll actually listen and learn from our esteemed international speaker, Professor Dr. Carlos Barrios, and he is actually the Director of Oncology Research Center in Sao Lucas, actually Brazil, co-founder and Director of Latin American Cooperative Oncology Group, Adjunct Assistant Professor, William Harrington, Latin American Program, actually University of Miami School of Medicine. Over 250 clinical research trial. If you see the Googles and the YouTube, actually you'll find is a lot of talks in both breast, lung, and kidney actually. A strong advocate of the international research collaboration in Latin America. Over to Professor Carlos.
Thank you very much, Dr. Mohapatra, for this very kind introduction. And just like you can clearly see, my picture in the previous slide and the credits are a little bit outdated. I used to treat lung cancer and kidney cancer for some time because of clinical research activities. Now, over the last 5 to 10 years, I have only dedicated myself to breast cancer. You can hear me well, I presumed. Is that correct?
Yes, sir. Yes, sir.
Okay. Okay, let me share my slides. Can you see my slides?
Not yet, sir.
Now?
No, sir.
Hold it 1 second, please. Let me try to do this again. Sorry for this confusion.
Perfect, sir. So we can see your slides. If you can just put it into presentation mode.
What about now?
Perfect, sir.
Is it moving?
Yes, sir.
Okay. So over the next 30 minutes or so, after this very appropriate and introduction by Dr. Patra, I'm going to discuss something that probably all of you already know. You know the data. So the most important aspect of this presentation is try to put into perspective not only the disease, but probably pointing out what are we going to do in the next future in two different aspects. One, and this will come in the discussion, I'm sure. One, what do we do with our patients in clinical practice, which is a most difficult question and has a number of different dimensions. And obviously, what are we going to do and what are the unmet needs in terms of treatment development for these agents? These are my disclosures, mainly related to the development of clinical research activity, something I've been doing for over the last 25 years or so. And very importantly for all of you to know, whatever I'm going to say, this whole presentation reflects my personal opinion and not the personal opinion or the opinion of the sponsor of this activity. This is obviously important for you to recognize. Let us start with the obvious comments, and certainly you can all relate to this. This is well known. The survival of HER2-positive metastatic breast cancer, in spite of the data presented by Dr. Patra, as they have a very bad and aggressive clinical course, is improving, and it has improved since the introduction of anti-HER2 therapy, as you all are very aware of. And it is obviously something that is good news. And you see patients that have been diagnosed more recently actually have a much better prognosis, a much better survival, as we can clearly, obviously see. At the same time, it's important to recognize that when we compare the outcomes of patients with triple-negative breast cancer, they continue to be very poor. And this is true all over the world with the same curve, because we have not been able to change the outcome of these patients as of yet. And certainly, in this analysis that goes up to about 10 years ago, the cancer-specific survival... Hello? There is a microphone that is open, please. So the breast cancer specific survival, it's better for HER2 positive than for the other two subtypes, which is obviously very good news and has to do, obviously, with the introduction of treatment. And the most critical trial, in my opinion, that actually started to change the whole thing is from around the year 2000, actually published by Dr. Slayman in 2001 in the New England Journal of Medicine, showing that combining trastuzumab to chemotherapy actually led to a PFS, remember this number, of 7 months, 7.4 months, with a median survival of 25 months and an overall response rate of 50%. So remember these three numbers: 50% response rate, 7.4 months of PFS, and 25 months of median survival, 2 years of median survival, reported in New England Journal of Medicine in 2001. There is something from the biology of this disease that always surprised me. I have always been very, very surprised with the fact that this very complex pathway that is so essential to the cell, and it is related to very aggressive clinical behavior, can be impacted clinically with the results I just showed you by just blocking one of these receptors in one specific spot. So this complex biology, I think that demands, in my opinion, much more aggressive therapy than just blocking one receptor in one single place. And I will elaborate in this biological clinical relationship across the presentation as we move along in the different aspects of what we will be discussing. The next important trial that was already mentioned by Dr. Mohapatra is the Cleopatra trial that was published in 2020. This is the final results, initially in 2012, and very clearly show that we have a significant impact when we combine two agents blocking the HER2 pathway with chemotherapy as compared to just a single blockade. So double blockade is better than single blockade when combined with chemotherapy. You see very impressive results. The median PFS goes from 7 months in the previous trial to 18 months, and the survival goes from 25 months to more than 56 months of median overall survival. The response rate that is not in the chart here, it's around 80% of the patients. So I think that this double blockade, just blocking the pathway a little bit further than with single agent trastuzumab, actually leads to a very significant impact in the results that we have clinically. Very importantly also is that 8 years later, after starting therapy, 8 years later, 16% of the patients remain in the first line treatment with double blockade as a maintenance, as you know, this treatment implies in using the chemotherapy only for the first few months of therapy. So very importantly, about 35, 37, 40% of these patients actually are alive at 8 years. Probably some of these patients are cured, although we have not been able to single them out from the group overall. But these results are obviously important. As I was mentioning in the introduction, we have not been able to significantly impact the results after this publication by Sandra Swain a number of years ago. So what happened since then? The introduction of T-DXd, among other things that are happening, is the most impactful at the present time. And I'm just summarizing the development of the T-DXd in this specific area by showing the results of the median PFS with Breast-03 compared in second line after progression in a Cleopatra-like regimen versus T-DM1, which is the standard treatment. And you see a very impressive 29 months of PFS in the second line was compared to T-DM1 when you use this T-DXd, a new way of addressing HER2-positive disease. And this is obviously associated with a significant impact also in the overall survival, with 52 months, exactly the same number of median overall survival we had before in this kind of situation, but in second line in this group of patients. Very importantly, this kind of results led to the development of the Destiny Breast-09 trial that you are all aware of. I'm going to go very quickly presenting these results because, as I mentioned at the beginning, the most important part of this is how do we interpret these results. And I'll try to give you my opinion on how to do this. This trial included patients that had disease that was metastatic, HER2 positive, and had a disease-free interval of more than 6 months from the last chemotherapy or anti-HER2 targeted therapy in the neoadjuvant or adjuvant setting. 1 prior line of endocrine therapy was permitted, and no other prior systemic therapy for metastatic breast cancer was allowed. Patients were randomized. In each group, you have about 380 patients to receive T-DXd plus placebo. We do not have the results as of yet of the outcomes of this group of patients. We have second group with T-DXd plus pertuzumab, and we have the standard THP approach of the Cleopatra regimen that we mentioned before. PFS was the primary endpoint of this trial. This was presented by Sarah Tolaney at ASCO about 6 or 7 months ago. At planned interim analysis, this is an interim analysis, the results were presented for the T-DXd plus pertuzumab versus the Cleopatra THP arm, as you all are aware of. The single T-DXd arm has no reported results at this time, and this will remain unblinded until final PFS results are presented. The results are positive, suggesting that T-DXd plus pertuzumab is better than the Cleopatra regimen with an 85% response rate. You see the 78.6 response rate, similar to the 80% response rate you would expect with the Cleopatra regimen. We have about 15% complete response rates with the TDXT arm. And you see there the median duration of response that was longer with the TDXT pertuzumab as well. So not surprising results for the control arm and better results for the TDXT arm, as you would have expected when you look at the previous data that I presented on the second line comparison. If you look at the primary endpoint of the trial, the results were significantly better. But let's start looking at the control arm first. And you see that it's 26.9 months of median PFS for the Cleopatra regimen are significantly better than the 18 months that were reported in the Cleopatra original study. Okay, suggesting that the patient population that was included in this trial is different from the patient population that was included, in my opinion, in the Cleopatra trial. But with a 13 months absolute delta and with 40 months of median PFS, you see an impressive hazard ratio of 0.56, a very significant result from the statistical point of view and from the clinically meaningful point of view, favoring the TDXT plus pertuzumab combination when you compare it in terms of PFS with THP, in spite of this very impressive 26, 27 months of PFS that is much longer than you would have expected with the Cleopatra regimen initially. Important, these results are interim analysis. 40% of the patients are still receiving treatment, so results may change with future analysis. So we should be expectant in terms of what future analysis will be reported from this trial in the next couple of years. So this is important. So very critically, we all know, but we need to look at this when we analyze trials, that not all HER2 positive patients are the same. And the most obvious difference in these patients is that we see patients that are hormone receptor positive, as was also mentioned by Dr. Mohapatra at the beginning, and they are hormone receptor negative. Concentrated in the hormone receptor positive results, the PATINA trial was presented by Dr. Metzer at San Antonio about a year or so ago, and showed very, very dramatic improvements in the PFS when you optimize the treatment of hormone receptor positive, that besides giving double blockade with anti-HER2 therapy, you actually optimize the endocrine therapy, something that was not done in the Cleopatra regimen. So the Cleopatra regimen, original Cleopatra regimen, could have probably been improved if you had treated these patients with hormone receptor positive disease in a more optimized way. And these results are obviously impactful. 44 months of median PFS is an extremely important result and very, very critical in this trial. It's important to consider that these patients were randomized after 6 months of prior induction therapy. So this doesn't include the patients that actually may have progressed in the first 6 months of treatment. So this is an important difference that needs to be taken into account. Important to consider, if you look at the evolution of these treatments, double blockade plus chemotherapy as a first-line treatment in the Cleopatra regimen in long-term follow-up gives an overall response rate of 80%, a PFS of 18 months, and a median overall survival of 58 months. And now, in this group of patients selected by having hormone receptor positive disease after 6 cycles without progression, you have a PFS of 44 months with an overall survival that we expect to be significantly longer. So we are evolving when we identify a specific patient population and treat these patients according to this biology. This is a concept that over the last 20 years, we have been clearly, I used to say that This is the most important aspect in oncology in general that we have learned over the last 20 years. If we select the right group of patients, if we identify the right biology, and we treat that biology, we definitely improve outcomes of our patients. There are issues with the implementation of this trial in practice. We need to recognize these patients are having a different biology. We can salvage these patients that do not respond or have early progression to the first 6 cycles. We need to identify these patients, and they need a different approach. Certainly, CDK4/6 inhibitors improve the outcomes of these patients and need to be incorporated in this treatment. What are the long-term outcomes and the PROs of these patients? This data are becoming a little bit more aware in the next few congresses that will be presented. But the most important aspect of this trial is that as we identify a hormone receptor positive patient population and treat this patient according to that biology, maybe we should look at the rest of the patients with HER2 positive disease and look at PI3 kinase inhibitors and see if we can introduce this treatment for these patients. We can look at ESR1 patients that may be mutated. We can look at BRCA1 patients. We have to look at PALB2 patients. And maybe this different group of patients may require different approaches on top of the anti-HER2 blockade. So this is a challenging, provocative thought that may be actually helping us looking at the future for future trials addressing these different specific populations. In this regard, there are already trials ongoing trying to identify patients with HER2 positive disease and PI3 kinase mutations and being treated specifically with combinations addressing that particular biology. So I think that we are learning as we move along to identify these subgroups and treat them accordingly. Importantly, the HER2 climb 05 that was also mentioned at the beginning was recently presented that also shows that a different maintenance in this regard has introducing tucatinib to the double blockade actually leads to a better results when you compare it to just the double blockade. This is important results as well, 24 months versus 16 months with the HP regimen by itself, a differences of almost 9 months. That this is an important concept that goes back to the biology that always surprised me, the complex biology of this disease I mentioned at the beginning. And here, very importantly, what we're doing is we're doing triple HER2 blockade. And as we increase our ability to block this pathway with obviously toxicity tolerance, okay, we get better results. So blocking with trastuzumab is okay, it works. Blocking with double blockade, trastuzumab and pertuzumab, is better. And triple blockade, it's better here. So I think that this is a consistent story that tries to bring biology into clinical results that I think we need to pay attention to as we move forward with new trial development. But let's start looking at the DB09 trial again with a little bit more careful look. Do all the patients included represent our clinical current practice? The patients you see in your office every week. And here are the characteristics presented by Sarah Tolaney at ASCO a few months ago. And you see that most of the patients, about half of the patients, were from Asia, okay? And that may or may not have an impact on the results. It's something that can be argued. And very importantly, and consistent with some of the new results, 50% of these patients had de novo disease. These patients had not been previously exposed to any anti-HER2 therapy. Okay, in the HER2 climb 05 study, 70% of the patients were de novo disease, and this is an ongoing situation where we are curing most patients treated in the adjuvant setting with neoadjuvant and adjuvant strategies. And most of the patients that will be treated in metastatic trials do have de novo metastatic disease, which obviously changes because you have different outcomes in patients with de novo disease as compared to patients that had been previously exposed to anti-HER2 therapy. And that's something that we need to consider for future trials designs as well. So you have about 54% of the patients with hormone receptor positive disease. And very importantly, and something of a limitation of this study, that concurrent endocrine therapy that we know after patina, it's important in the outcome of these patients. Only 13% of the patients in the TDX arm with pertuzumab receive concomitant endocrine therapy. And only 40% of the HP patients actually receive endocrine therapy. So that's a limitation of the trial. In both arms, the results could have been improved if concurrent endocrine therapy would have been administered. But most importantly, if you look at the number of patients that received, remember 50% of the patients were de novo, and only 30% or so of the patients had received prior trastuzumab, something that in clinical practice, most patients with adjuvant therapy do receive trastuzumab, at least in my country, in the adjuvant setting. And pertuzumab, only about 8% of the patients actually did receive pertuzumab prior to developing metastatic disease. So this is a limitation in the kind of patients that actually were included and may actually represent an explanation for why the control arm actually performed that well, and actually explain why the experimental arm actually also was so effective in at least the outcomes that we have available out of this analysis so far. So two important concepts of this analysis: low use of prior anti-HER2 therapy, even though considering only 50% of the patients had recurrent disease, and low use of endocrine therapy prior to this. But if you look at the subgroup analysis, which obviously is important, with de novo recurrent hormone receptor positive disease and PI3 kinase mutations, you see that the results seem to be rather consistent in spite of what I mentioned before. The results of de novo recurrent doesn't seem to be very different. Obviously, hazard ratio for de novo disease is a little bit lower, 49 versus 63 for recurrent disease. The hormone receptor status doesn't seem to change much, and the PI3 kinase mutations also don't seem to have a major difference. If you look at, this is PFS, if you look at the response rate, looking at this situation, you see some information that I think are extremely important. In de novo disease, you have 90% response rate in this group. In hormone receptor negative disease, you have 90% overall response rate. And in PI3 kinase not mutated disease, you have 87% response rate. So very impressive numbers for this quote unquote best responding group of patients that we have seen. And these are the curves from PFS showing exactly the same data that you saw prior in the forest plot analysis, and that shows the same concept, that the better prognosis patients actually have better outcomes in this kind of analysis. Very importantly, and I think that very critically, not for the PFS analysis, but for the overall survival analysis, that everybody is wanting to know what will happen in this analysis, you see the post-progression treatment. And this is something that we have not consistently documented in most phase 3 clinical trials, I would argue. I think that we need to do a much better job of recording post-progression treatments in most phase 3 clinical trials that we are running. Importantly to consider, a significant number of patients did not receive post-progression treatment, and that needs to be explained. What happened with these patients that did not receive any second-line treatment in this kind of situation? And very importantly, and some of the criticisms have been heavily being given to the analysis of this trial, is that a very small proportion of patients in the THP arm actually received TDXD in the subsequent treatment. We know that TDXD works in second line, but most of these patients actually did not receive TDXD in second line. So that will definitely have an impact in the analysis of overall survival when that becomes available. But PFS2 was obviously better in the patients treated with TDXD, although those caveats I just mentioned are obviously important to consider. What about toxicity with this TDXD administration? Median PFS of 40 months is something expressive. How did patients actually end up tolerating this treatment? And I was very surprised with these results presented by Sarah Tolaney. Very importantly, you see that if you look at treatment emerging adverse events, they were very similar between both arms, very same numbers. If you look at the grade 3 events, they were very similar as well, 97 and 96%, 54 and 52 when you look at the grade 3 events. Serious adverse events were very similar, 27 and 25. When you look at the treatment adverse events associated with treatment discontinuation, this is the first surprise. These were more common with THP, 28%, than with TDXD and pertuzumab. Okay, probably this 25% of these were due to the taxane administration. And in my opinion, this is a little bit higher than what I see in my clinical practice in particular. If you look at dose interruptions and dose reductions, you see larger numbers for TDXD and pertuzumab, and treatment-related death was 5 in the TDXD arm, and we'll detail this in a minute, and 1 in the THP arm. Very importantly, about 8%, 7%, 8.7%, 9% of the patients in the THD arm, and this is important for our discussion later, that discontinued treatment because of whatever toxicity actually received HP maintenance as a follow-up. And that group, knowing what happens to that group, will be an important addition to our analysis of this trial as we move along with further analysis. If we look at ILD, certainly the elephant in the room, and left ventricular dysfunction, you see that there was about 12% of ILD, with about 2 patients dying from ILD in this trial. These numbers are not different from what we would have expected in the treatment of patients with TDXD. And from the left ventricular dysfunction point of view, you see 11% of patients with left ventricular dysfunction. Again, nothing that is extremely surprising for this kind of situation. If you look at overall, you see that there were a number of grade 3 toxicities that were more common with TDXD: fatigue, nausea and vomiting, anemia, thrombocytopenia, and hypokalemia. Overall, analyzing the toxicity of these 2 regimens, there were no unexpected toxicities. We need better information in terms of what were the early toxicities and what were the particularly comparing is extremely important in the main message I would have with this study. This is when we discover HER2 as a major driver. Trastuzumab was initially documented at the end of the 90s, beginning of the year 2000s. In 2007, we discovered the TKIs, and lapatinib was approved for second-line treatment in combination with capecitabine. Double blockade with trastuzumab and pertuzumab in the Cleopatra regimen was initially reported in 2012. TDM1 was soon after that developed and approved for second-line treatment. Later on, a number of agents over the last 5 to 6 years were developed: deruxtecan, tucatinib, margetuximab, neratinib, and others that are in development. And obviously, in 2025, to have the development of DB09. But if we look at these results in terms of actually what has really happened to our patients in terms of clinical trials, we see very clearly here that we had chemotherapy in the year 2000 with first-line treatment for HER2-positive disease with an overall response of about 30%, a PFS that was 4 months, and an overall survival of 20 months. This was the control arm of the Slamon trial published in 2001 in the New England Journal of Medicine. We evolved with the combination of the Cleopatra regimen with response rates in the order of 50% with trastuzumab alone, PFS of 7.4 months, and 25 months of overall survival. This we evolved with the double blockade, with increasing the overall response rate, as we mentioned, to 80%. PFS went up to 18 months, and the overall survival went to 58 months. And now we have, with an ADC with pertuzumab in first line, an overall response of 85%, a PFS of 40 months, and an overall survival that we expect to be in excess of 60 months. So I think that we definitely are improving our results in a very significant way, and this needs to be considering. Before closing with a few details that I think are important for the discussion, I think that it's unquestionable that we have a significant advance in our management in these patients with the introduction of TDXT. It's a better agent, gives us better results, and certainly we need to find out who are the best patients to treat with TDXT. We may need to consider at some point when we discuss this, the possibility of curing, and I put that in capital letters, a larger proportion of patients than we were used to cured with the Cleopatra regimen. Those maybe 18% that remain PFS, remain without progression after 8 years, or some of those that are already alive, of those 37% that are still alive at 8 years, may be actually cured of the disease. What happens if we have a better, a more effective therapy and raise those numbers significantly because we use TDXT in the first line? We can also consider TDXT at later lines and still improve these results, although that needs to be proven. Toxicity issues and PROs will be important to inform clinical practice. The PROs were presented at San Antonio of the Destiny Breast 09, and there were no surprises there. The treatments were reasonably well tolerated in both arms. And obviously, the most important aspect in line of this concept that I mentioned before, the most important thing we have learned in oncology over the last 20, 25 years is the fact that if we select patients according to biology with specific biomarkers and treat these patients accordingly, we do improve the results. So selecting patients with new biomarkers or combination of biomarkers, and most importantly as well, sequencing strategies with combinations do remain an unmet need to improve further the results I'm just presenting. And just to finish this discussion with a couple of provocative issues, you see here the results of the Cleopatra trial in the long-term run. And here you see that some patients may be cured from the disease with single-agent trastuzumab in the blue curve and double blockade and chemotherapy in the red curve. We discussed this at the beginning. But this actually makes the point that we need more treatment for all these other patients that are not in this group. All these patients need better treatments. This is a significant unmet gap that we need to recognize. This is an unmet need we need to try to solve. And TDXT may represent one of the possible solutions. The combination of endocrine therapy or the introduction of triple blockade may be able to improve some of these results as well. But we need to recognize that we remain with a significant proportion of patients that actually needs to be treated in a better way. And if you look at this group of patients, these are an heterogeneous group of patients that likely will require different treatment approaches. I do not think that there's going to be just one approach for all of them, with different agents and different sequencing strategies. And in that regard, we are currently running a trial that is called Demeter. You are all aware of this trial. That is looking and participating in this trial in the steering committee of this trial. We are finishing the recruitment as we speak. I think that next month, in March, we will finish the recruitment of the predicted number of patients of 165 patients that actually looks at an induction phase followed by maintenance by double blockade. And we'll just need to learn what kind of answers this trial actually will give us, because this is something of a strategy that many people actually think may be better. I'm not sure. We'll just need to wait for the results. Just in case, just to remind you that about 9% of the patients in DB09 actually did exactly what we're talking about here. Switch to HP due to TDXT related toxicity. The only difference there that we don't know exactly how long these patients actually received the TDXT before switching to HP, as a difference from the Demeter trial. So with that, I would like to thank you all for your attention. I hope that this was not too complex and maybe have been, and this is my objective, provocative enough in order to generate a fruitful discussion that we can all learn from. Thank you very much for your attention.
Thank you, Professor Khan. And actually, this was an excellent talk, actually. And in-depth analysis of the HER2-targeted therapy, especially Destiny 9. And I think there will be much questions, actually. I think questions will be answered in the panel discussion. And panel discussion will be Madam Dr. Jyoti Wadhwa. She is actually the consultant and lead consultant in Apollo Hospital, Delhi. And she has 30 years of experience, actually. She has done the DM from the most premier institute of India, that is All India Institute of Medical Science. She's excellent moderator. More about the madam.
Thank you, Dr. Mohapatra. And Dr. Carlos, I'm sure the panel discussion has become easier after listening to you. You have made it very extensive. Just allow me to share my slides, please, if you stop sharing. And if the AZ team could invite the panelists.
Ma'am, I would like to
Meanwhile,
invite
madam,
Yeah,
meanwhile,
Himanshu.
can I ask? Yeah. Meanwhile, can I ask
Dr.
one
Vivek,
question
go
to
ahead.
Dr.
Dr.
Carlos?
Carlos, yes, please.
Yeah. Dr. Carlos, I would want to ask this again, a provocative question again. That there are a group of patients, a significant chunk of patients where we are not able to cure, but now with such effective treatments like TDXD in first line, and then giving them hormonal treatment with CDK4/6 inhibitors or triplet maintenance, we can have a significant chunk of patients who would be doing well. Now, in in such a setting, would you see that giving local treatment to metastatic disease, treating the residual disease with local treatment, whatever is there, this is one strategy which can, improve survival and increase cure rates in the patient. What is your view about this?
I have thank you for the question. I think that is an excellent question. Let me step back a little bit and think a little bit about biology. Okay. All right. I think that none of us that work in oncology has any question that if you think about a primary tumor actually is a source of metastasis. Cells from the primary tumor actually are all the time actually generating metastatic disease. Correct? We all agree on that. Okay? Any metastatic site actually does the same thing, if not more. Is that correct?
Yes.
However, we have not developed specific strategies to deal with that specific biology. Most of the guidance that we have tells us that we should not treat a metastatic disease concentrated in local therapies unless you are palliating the pain or bleeding or something of the sort. Okay? And I understand that when your local approach is not feasible and doesn't cover all the disease that you can see. But if you have one metastatic site, I think that we need to look at that metastatic site from the biology point of view as being a potential source of metastatic cells. So not considering that, I think, is a disservice to the patient. The question here is it has two aspects, two dimensions. First is how much of the metastatic disease are you actually aware of? And second, do you have a local strategy that is actually feasible? So if I have two metastatic bone lesions, I can easily today treat them with radiotherapy in an ablative way. So there is no reason why not to do that. Okay? If I have visceral disease, if I have many visceral metastases, that may not necessarily be possible. The main concept here, Dr. Arwala, is that we need to consider that not all metastatic disease patients are the same. And there are patients that evolve very slowly, and there are patients that may be amenable to local approach combined with systemic approach, because after all, this is systemic disease already. So I think that most of the trials that have addressed this question, that I think is a very important question, have not been able to single out those specific patients that may actually benefit. In my practice, whenever I tell the residents, you need to let the patients to select themselves. So if the patient responds very well to systemic therapy, if it just has one metastatic disease site, or it has a couple of metastatic disease sites, or it has a number of metastatic disease sites that is amenable to radiation therapy, okay, we certainly need to let this patient go into a pathway of treatment that may be a little bit more aggressive, okay? So that's my clinical perspective on this situation, although I recognize that the clinical trials that have been performed so far have not addressed this in the exact same way. Does that help you?
Sure, sir.
Yeah. So Himanshi, are you going to introduce the panelists?
Sure, ma'am. Ma'am, I would like to invite our panelists, Dr. Carlos Barrios, Dr. Rajiv Bhattacharya, Dr. P.M. Mohapatra, Dr. Paulimi Basu, Dr. Samit Purohit, Dr. Akhil Kapoor, Dr. Pankaj Goel, and Dr. Vivek Agrawala. Over to you, ma'am.
Okay, so let's begin. And Dr. Carlos just took us through all the anti-HER2 therapies as to how they have evolved over the years. And from long ago when it started with Dennis Lemon in 1998 and to now in 2026, let's see as to how best can they be sequenced. So these are some of the objectives of today's panel discussion. And the focus would mainly be on DBO9, but also talking about the biomarker testing and sequencing of the treatment options. Dr. Mohapatra mentioned about this as to how over the years the unmet needs in HER2 positive metastatic breast cancer were identified, and as to how some of them only have been solved till date, but a lot many more are yet to be solved, especially the increasing emerging role of the biomarker testing, and as to how we can offer differential treatment to these different subsets. So let's begin with this representative case. A 66-year-old lady who was treated for carcinoma of the breast. It was hormone receptor positive, HER negative. She underwent breast conservation surgery, followed by the adjuvant chemotherapy and radiotherapy and adjuvant endocrine treatment, which she went on to complete 5 years of. And then when she was 71, she presented with new symptom of cough, dry cough, and dyspnea on exertion. A CT scan was done, a PET CT in fact, and it revealed multiple pulmonary nodules. One of them was biopsied and it confirmed metastatic breast cancer. The IHC confirmed it to be hormone receptor positive, but also HER2 3+ by IHC. The treating doctor had ordered MRI of the brain also, which was negative, and the patient was in good performance status. So let's begin. So beyond this IHC testing, would you do any other biomarker at this point in time? So let me start with you. Dr. Vivek, you could start.
Yeah, ma'am, in the current scenario, I think I would not do any more extensive testing. Yes, there is role for PIK3CA testing. There is role for, more advanced HER2 testing like HER2-DX scores and all that is going to come in future. But I think as of current, I would not go for any further testing because I think my first line of treatment will not change.
Right. Dr. Samit, what about you?
Yeah, ma'am. So I'll definitely do a PIK3 and ESR1 mutation testing just to see the patient was on hormonal therapy and now has relapsed after 5 years on hormonal therapy. Having said that, the treatment regime which I'll be opting is pretty much decided. It will be either the one of those
We'll come to
Cleopatra or
that. Yeah.
DTxT.
We'll come to that in a bit.
Yeah. So
Okay.
two of the markers I'll definitely do. Yeah.
Okay. Dr. Pankaj, I could see you.
So, ma'am, I am again a bit conservative on this. I'll not be asking for any further mutations because that will not change my initial treatment plan.
Okay. This question, according to me, is important. And Dr. Polomi?
Yes, ma'am. At least PIK3 mutation test we do.
So you would order just that, or you would go beyond that?
PIK3 mutation and ESR1, but PIK3 mutation, even if it is positive, the treatment is same, but it's a prognostic value, so we do PIK3 mutation.
So are you saying that you will order it now at the diagnosis of metastasis, at the time of diagnosis of metastatic disease?
Yes, ma'am.
Okay. Dr. Mohapatra, do you order anything beyond what I have already shared?
Same PIK3CA and ESR mutation.
Okay. So Dr. Carlos, let me ask you now. So in your practice, in a case like this in 2026 now, Do you order any further biomarkers, or do you just start with the first line treatment? Do we have Dr. Carlos with us?
Yeah.
Excuse me, I was muted. My principle, as some of the members of the panel mentioned, is that I order a biomarker if that is going to change in any way my treatment approach. Okay, we are running a trial with inavolisib in this group of patients with HER2 positive disease, a trial that is completing recruitment as we speak, which is INAVO 122, looking at inavolisib plus double blockade in this group of patients and endocrine therapy in patients with hormone receptor positive disease. But in clinical practice, that doesn't have any impact on what I do. Okay, so I do not order. I understand some of these patients have worse prognosis, but that doesn't change the way I approach treatment at this first line.
Okay, so lastly, let me ask you, Dr. Akhil, are you doing it for practice, or since you run a lot of trials also, you are deep into research as well? So what's your approach?
So, ma'am, as Professor Carlos told that mostly they do not affect our treatment regimen unless I have a trial which is trying to look at some additional treatments like Professor Carlos highlighted about INAVO 122 trial. So some similar trials, there is a subset of patients where these treatments might help, but we don't know whether it is going to change. And the DB09 subgroup analysis also told that even prognostic information will not change if the patient is having any additional mutations like PIK3CA.
Yeah, since it works in both.
Yeah.
Okay. So, what treatment would you recommend for a case like this? Dr. Rajiv?
Ma'am, for an occurrent de novo metastatic breast cancer, HER2 positive as well as hormone positive, I think I am happy with Cleopatra right now, maybe followed by the Katina maintenance approach.
Okay, so Cleopatra. And Dr. Pankaj, what's your approach like in a case like this?
So I'll also go Cleopatra way, though the chemotherapy which I'll start initial, I'll go with the weekly schedule. And after 3 weeks, when I'm sure the patient will be able to handle the full dose, then I'll possibly go in 3 weekly schedule.
Okay. Dr. Vivek, what's your take?
Yeah, ma'am. I will agree with both of them on this, ma'am, because when you see the subgroup analysis of Destiny Breast 09, one thing that startlingly you see is that the patients who were more than 65 years of age, that is one subgroup where that is not seen to be benefiting. Now this patient is 71 years old, so I think I will go with the Cleopatra strategy followed by Patina. I think that is something that I would look forward to. And yes, I may explore doing a liquid biopsy in the maintenance phase to look at, the PIK3CA and the ESR1. This is something that I would want to do later on in the liquid biopsy rather than upfront.
Right. Dr. Joydeep? Dr. Prashant, is he part of the panel? Okay. So, Dr. Samit, your first line treatment for this 71-year-old patient.
So I've been using Cleopatra regime in my patients, and now with the results of Destiny Breast 09, I'm actually tempted to use TDXT plus pertuzumab combination. So I would want to use this new combination.
Dr. Carlos, is that age of 71 a hindrance to offering DB09 for you, or is there something else in the case that would take you away from offering DB09?
You didn't present anything in the clinical picture of this patient that actually precludes her from receiving TDXT and pertuzumab. Let's say not all 71 year-old patients are exactly the same.
Correct.
And I'm very particularly touched by this because I am 71 years of age. And if I would have been a candidate for a treatment that could be better, okay, I would actually like to receive that treatment and have the chance of having a better result. So if you have somebody that has a lot of comorbidities and you're worried about the tolerance, et cetera, I would definitely agree with the fact that sometimes age is an important discriminant. But this patient would have been a candidate and would have been able to participate in DB09. And that potentially is an important first distinction. Before we move on in the discussion, I think that one of the important aspects that I think we need to put into context from the clinical point of view is that with every new therapy that we bring into the market, there is an issue of tolerance. Okay. And if you have a group of patients that actually can tolerate 44 months of PFS, okay, these patients actually exist. And these patients are in your clinic every single day. And we need to have, we need to give them a chance of receiving that treatment. Obviously, there is no problem with a patient that doesn't tolerate treatment, and we all have that in clinical practice, and change treatment to something that is alternative. But the beginning of the treatment at the present time, I think that with the data that we have available, okay, it's with TDXT and pertuzumab.
Yeah, so I concur with you that for a fit patient without any obvious contraindication to the use of TDXT, just the age, just the number should not be a deterrent for us medical
Thank you
oncologists.
for that comment. I feel a lot better being 71 myself.
Yes. So let's move on. So this is how the current NCCN guidelines look like, and we are all aware. Moving further, the ESMO guidelines also, and we have seen this data, and Dr. Carlos shared with us this beautifully, the Cleopatra followed by Patina approach, how it led to a significant jump in the PFS in the hormone receptor positive. And we are all in our practicing, we are practicing this approach till now. That was our preferred approach. So, coming to this next question, in your practice, what has been your experience with this Cleopatra regime, the THP? Do you face any real challenges? What's your taxane of choice, if that is the difference in your practice, or do you face any particular challenges? Let me start with you, Dr. Akhil.
So, ma'am, I just wanted to make a comment about geriatric evaluation. So,
Yes.
geriatric evaluation is really very important part of the workup now, and all of us know that in India now we are evaluating patients above 60 to 65 years for geriatric oncology. So, we have a dedicated clinic where we evaluate these patients. Coming to this question, I think again the usual choice remains docetaxel. But there are some patients where we know, and from our, if the patient is in geriatric case, the geriatrician tells that the patient has previously existing ILDs where docetaxel might be having its complications. Then in some selected patients, we switch to, we utilize paclitaxel, but default choice remains docetaxel. Otherwise, during the induction phase of 6 cycles, sometimes we have to stop after 4 or 5 cycles. So initial 4 to 6 cycles, the induction phase is the only issue. Otherwise, there we all know TRAS2 plus PER2 maintenance is the best part. And as Professor Carlos was highlighting about the DEMETHER trial, so that is the trial which all of us are looking at. So give a good induction and go to a maintenance treatment that can improve the quality of life of the patients for the time. So that is what we are trying to. We are all are eagerly awaiting for the trial.
Yeah. Dr. Vijay? No? Dr. Samit, any challenges that you face with THP protocol? Dr.
Yeah,
Pankaj?
can I make a
Yes,
short
yes,
comment
please.
here
Yeah.
that comes to mind here? If you look at the comparison that was made in DB09, actually the chemotherapy was prolonged in the experimental arm in a significant way because we continue with the chemotherapy throughout the treatment, okay? And in the THP arm, we stopped the chemotherapy. Okay.
Yeah.
So essentially, maybe a more fair comparison would have been to continue the chemotherapy until tolerance and see what happens. Okay. So I think that's an important concept. Just because it's clinical practice and just because the Cleopatra regimen was designed this way, this doesn't necessarily mean it's the best approach for all patients. And we all know that our patients that continue to tolerate chemotherapy and we just stop the treatment because it is the Cleopatra regimen. Okay, so I think particularly with weekly paclitaxel, okay, many patients actually tolerate weekly paclitaxel absolutely well without any significant problem. So I would consider the possibility of continuing chemotherapy and that being a more quote unquote fair comparison with the TDXT more to a long time.
Yeah, exactly. So I agree with you there also that docetaxel also we could go beyond 6 cycles there also. And especially if the disease continues to respond, we continue to see, decreasing tumor burden at end of 6 cycles also. I think that does make sense. And so is any of us in the group, Dr. Vivek, you or somebody else could come in. Are you offering beyond 6 cycles? Keeping that logic in mind.
Yeah, so madam, I don't prefer to use docetaxel because docetaxel along with pertuzumab, a lot of my patients have diarrhea, and that is why I am more used to using weekly paclitaxel. And yes, in some of the patients who don't have neuropathy, who are young, who are fit, I have used it, beyond 12 cycles of weekly paclitaxel to sometimes 18 cycles or 24 cycles, but I have hardly gone beyond 24 cycles of weekly paclitaxel.
Dr. Pankaj?
So, ma'am, if you look at this Cleopatra trial, they have gone to maximum 8 cycles. So that is what I do. 6 to 8 cycles. Usually, I start with a plan that will go for 6. Then I might extend for another 2 cycles depending upon the response and the tolerance. But usually it's 6.
Right.
Can I,
Dr. Polami?
Ma'am, mostly docetaxel we use and mostly 6 cycle.
Right.
Sometimes when patient general condition poor, we use weekly paclitaxel.
Right. So let's now focus a bit on DB09. And we heard these, we are all aware of the study design and the results. And actually, Destiny Breast 09, it aimed to cover multiple unmet needs within this single trial. And looking at the patients with brain mets because they were excluded from the Cleopatra. However, in DB09, they were very much a part of the study. And attempt was made to also look at the potential prevention capability in terms of development of brain mets with the TDXT. And the biomarker testing that has been looked at in a big way because the patients were stratified as per the hormone receptor status, the PIK3CA mutation status. And I'll take you through the subgroup analysis shortly. So this is the PFS curve. Impressive delta there between the TDXT with pertuzumab versus the THP protocol. And this is the investigator assessment. Again, clinically meaningful improvement seen in the TDXT with pertuzumab arm and overall response rates, impressive improvement in the median duration of response there. Coming to the biomarker testing and their relevance. So does the presence of these co-mutations, namely the PIK3CA or the hormone receptor status, whether it's positive or negative, does that alter in any way your decision making when you are considering the first line treatment option for these patients? Dr. Rajiv is there?
Yeah.
Am I missing out anyone? Dr. Rajiv is there. Yeah.
So, ma'am, as per the DB09 subgroup analysis, we have seen that in both the PIK3CA mutated and the hormone positive patients, they do derive benefit from TTXT. So, in case I use TTXT and pertuzumab for DB09 regimen, in that case, I think this will make no difference. And that's the reason why
upfront
Mhm.
many of my patients with HER2 positive breast cancer in first or second line setting.
Okay. Dr. Akhil,
Yeah, ma'am.
does the hormone receptor status or PIK3CA let you choose one over the other? Say if it was hormone receptor positive, you would prefer Cleopatra followed by Patina strategy. And if it's negative, then you would offer DB09, something like that. Are you doing?
So till now, we have seen this data, DB09 subgroup data, which you are also trying to highlight. Hormone receptor positive patients are also doing very well. It is not that they are not doing well with this regimen. So if we feel that the patient and we evaluate the patient in clinic and find that the patient is not fit for TDX plus PER2, then the question of choosing this Cleopatra followed by Patina will arise. So I think the default choice automatically becomes DB09, irrespective of hormone receptor status. But definitely, hormone receptor patients, we are, if there is any contraindication, any doubt about TDX tolerability, then we can choose Patina approach, ma'am.
Dr. Samit? If
Ma'am,
not,
I think I'll concur with Dr. Akhil. We have seen in the subgroup analysis that irrespective of all these factors, PIK3, hormone receptor status, DB09 strategy outscores much better than the other strategies. So my choice would be DB09.
okay. And beyond these biomarkers, is there something else? Say some of them have been mentioned here in terms of the tumor burden, whether it's low or high, or whether the patient is slowly progressing or fast progressor, or whether or not there are CNS mets at diagnosis of metastasis. So any of these factors, Dr. Vivek?
So I think, ma'am, you said it very correctly that presence of lots of visceral mets, presence of brain metastasis, patient being, not treated with trastuzumab or pertuzumab in the previous neoadjuvant setting, HER2 naive patients, pertuzumab naive patients. So these are those patients, ma'am, fitter, younger patients whom I would be looking to give uh, 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 the DB09 protocol. We must also note that this is going to bring in a significant cost burden, and the tolerance of TDXD, whether all Indian patients are going to tolerate TDXD same as that of whatever is the DB09 data. That is also something that we need to look into. When you are giving TDXD, there is a lot of fatigue, there is a lot of nausea, and that is there in the patients, and there is a significant risk of ILD that remains in the entire duration. And
Yeah.
can you use the CDK4/6 inhibitor Patina strategy with the TDXD? Now you don't know. And when you see the PFS in the Patina, that is also 40-41 months. The same is the PFS with the DB09 also. So again, I think, ma'am, this is a very valid debate when you are saying that you would prefer Cleopatra followed by Patina in a hormone receptor positive patients and not DB09 unless they are very young, they have brain metastasis or something where you are compelled to bring in TDXD early on. You still have the TDXD with you for the second line or later line.
Yes.
Yeah.
Dr. Carlos, your views on, we have shared our concerns also, our Indian patients also maybe, we sometimes don't feel so confident, the performance status. What would you be, Would
I
you be
think that if you
considering
look at,
any of these factors, or
yeah,
you are just
I think
happy
that
to
is
offer
a,
it to most of your patients?
yeah, I think this is a very interesting question. I think that from biomarker point of view, I wouldn't make any difference as at the beginning of the decision. I think that the clinical aspects are interesting to discuss. For example, if somebody has a CNS metastasis, I don't think that any of us would have any questions that DB09 TDXT is a better option here than the Cleopatra regimen. But even if you look at fast progressors or slow progressions or having high disease burden or low disease burden, these are clinical factors that I do not believe are enough to discriminate between one treatment or the other. If you have a low disease burden, you may have a higher chance of developing a PCR or a CR, okay, when you use a better treatment. Okay.
Yeah.
And remember, 15% of these patients early in the analysis already have
Sure.
clinical CR. So maybe that number will increase, and I believe that that number will increase with time. So I think that these issues clinically are not important to select one or the other, with the exception of CNS metastases, where the selection for TDXT is mandatory. I think
Right.
that the most critical aspects is what you mentioned in terms of performance status and tolerance. Okay, so I
Yeah.
think that that's the critical aspect that the clinician in the offices needs to be taken into account. Those issues that you presented in the previous slide, I don't think that actually make a difference when you analyze the results from DB09.
Right. So we have seen this subgroup analysis, hormone receptor, PIK3CA. It works in all of them. And brain mets, definitely we are all convinced that TDXT is a better molecule, and we would offer DB09 protocol there. Coming to the efficacy, we are all convinced about, and safety remains a concern. And this table also, we saw the comparison between the two arms in terms of toxicity, interstitial
Can you
lung. Yeah,
go back one slide?
yes, this.
Aren't you all surprised with this with table? Because
Yeah,
you see
you took us
that there
through
is
this. Yeah.
more toxicity. There is more toxicity than we all would expect with the THPR.
Yes,
Okay.
this is more than what we experience in our practice.
That's right. So
Yeah.
I think that either that there is a problem here. We need more information here. Okay. These are equally toxic regimens, and this is what is being presented here. And the perception that we have is that TDXD has been sold as a much more toxic regimen. But if you look at this, which I presume is reflecting the early treatment, okay, we will need to see what happens with the late follow-up of these patients. But the early treatment tells us that these two regimens are practically similar.
Yes.
Okay, and this is surprising to me. I would like to call everybody's attention to this kind of information.
Yes. Any comments from any of the panelists about this?
Yeah, Right.
I think the data with docetaxel and trastuzumab combination is definitely we see patients where we need to stop and docetaxel after 4 to 5 cycles. So that makes sense actually. We don't expect all of our patients completing 6 cycles of docetaxel with trastuzumab, and this control arm is reflecting that data only. Even taxane dropout was considered as a any treatment discontinuation. So that makes sense actually. So definitely this convinces us that only TDX plus PERT is not toxic. The regimen which we are also utilizing is have significant toxicities. It is not without toxicities.
Yeah, sometimes giving the full dose of docetaxel also
Yeah.
becomes a big problem.
Correct.
Becomes a
Let
challenge.
me call everybody's attention also to the DB05 trial and the reporting of the toxicity of TDX key there compared to TDM1. And the same surprise is apparent there. The perception of toxicity for TDXT when you analyze it in a randomized clinical trial compared to another agent, okay,
it's much less than we actually have the perception in clinical practice. So it's just a provoking thought. Look at the data from DB05 and you'll see a very similar analysis in toxicity results.
Right. Dr. Mohapatra, a few words from you about the toxicity, the tolerability, and the safety profile of these two different approaches.
We've given a lot of THP actually. I think it's well tolerated. You go to a clinical trial setting and you see the patient in the ward actually is different. We have one trial, I think, is no small things you have to report it actually. Then comes actually the clinical trial actually. But we have given both docetaxel, paclitaxel. Only docetaxel if somebody have lot of diarrhea actually, we little bit change to paclitaxel. But we give 6 to 8 cycles as per the TDXD. We have given a lot of patient in actually metastatic setting also. We have not yet seen any interstitial pneumonitis actually. I think
Oh, that's great.
Astra people are very good in training everybody, every medical oncologist in how to diagnose early the interstitial pneumonitis, how to treat early. So when everybody is very cautious who are using TDXD, they know how to identify it is earliest actually. But I have not gone through any patient who have TDXD. But I think both the regimens are good, Patina is good. And this is a oncologist, as an oncologist, we have to find out which is the best for our patient.
Right. So in this study also, DB09, the most of the patients reported maintained or in fact improved physical function during the study, and it was similar across the two arms. This can be reassuring. This patient that we started our discussion with received the Cleopatra protocol, the THP, and she was also given, this is somebody else's case, she was also given tamoxifen. She continued this, had further progression with development of brain metastasis. Obviously, this takes us away from the first line treatment of metastatic breast cancer to second line. So obviously, since this patient did not get the DB09 protocol, the obvious choice, Dr. Pankaj, and then Dr. Samit could come in. TDXT now or something else?
I think no doubt, ma'am. TDX should be utilized as early as possible.
All right. This patient, I think, had multiple and warranting the use of radiotherapy. Anyone right now offering TDM1 also? If somebody can afford, is fit for TDXT? I'm sure we are convinced with this data of DB03.
Yeah.
Dr. Pankaj, are you there? Dr. Vivek, Dr. Polami? Dr. Polami?
No,
Dr.
ma'am.
Vivek? Okay.
No, ma'am. If patient is affordable, we go because this patient develop brain mets. So TDXD is our first choice.
Right.
Yeah.
Okay. So I think this patient warranted the use of whole brain radiotherapy. So let me ask you, Dr. Carlos, if somebody had brain metastasis, not warranting surgery for the brain mets, how much would you rely on TDXT so as to let go of any radiation?
A lot. I
Yes.
think that the evidence that we have is, we will be presenting at ESMO Breast some data specifically on that. There is a significant effect of TDXT, and when you can treat patient clinically with TDXT and forego radiation or delay the administration of radiation to a later stage. Obviously, you need to consider that the amount of disease that you have, and if you can do stereotactic radiation as well, okay? But TDXT has shown a significant effect, as you all know, in the brain disease. And I would, without a hesitation, use TDXT alone and delay the radiation without any problems.
Especially if the patient is asymptomatic but with multiple brain mets, you could definitely rely on TDXT.
Oh, yes, no question about it. I think that that's a fairly effective therapy for that kind of situation.
Yeah. So quickly, let me hear from all the panelists to begin with Dr. Samit, Dr. Rajiv, and then Dr. Akhil. So where do you place TDXT in your practice now? Dr. Samit, Dr. Vivek?
Hi, ma'am.
Yeah, Dr. Rajiv?
So I think I am the most convinced with DB03 data. I think that TDXD is best used in second line as of now because for me, I do not find much value for money in terms of Cleopatra versus DB09, except of course, as Professor said, in brain mets patients. So I think I will use TDXD as of now. If the patient is not upfront de novo brain metastatic patient, I will use it in the second line as standalone.
Dr. Akhil?
So I think, ma'am, we have we had a detailed discussion on the applicability of DBZ09 regimen. I think it is quite well tolerated, and TDX toxicities are overhyped. Like we have overhyped toxicities for multiple other treatment options, and we know once we are comfortable with the regimen, we learn to manage the toxicities. We become more comfortable, and that can be utilized in first line. So that is the case, and DB09 has become one of the favorite choice. It is only the patients who are not fit enough to receive the same will consider the Cleopatra regimen.
Yeah, and I would conclude here and bring in Dr. Akhil. Dr. Carlos mentioned about this. We would be looking forward to results of this study eagerly. And last comments from you, Dr. Carlos, and then we close this panel.
Thank you very much for this very interesting discussion. I think that very clear that we have a better treatment. And I think that there is a lot of emotional issues here of how frequently we have used the Cleopatra regimen before. And sometimes it's difficult to change. There is a perception that I think needs to be corrected of the toxicity related to TDXD. And by that, I mean that there is a specific group of patients that actually can tolerate TDXD for a long period of time. This is an important concept. It's just a question that we do not know who these patients are. And if we have a better treatment, we need to identify who are the patients that actually can tolerate it. And I don't have absolutely any problems in starting this best treatment and then changing if the patient doesn't tolerate it. Obviously, if the patient has access. So in my view, that's the best possible approach at the present time, particularly if we want or if we consider the possibility is that after 5 to 8 to 10 years, instead of having 18% of patients without progression, we may have 25 or 30% of patients without progression. And instead of having 40% of patients alive, maybe having 60% of patients alive. And that's the way we will be having the possibility of impacting more and more on the outcomes of this disease. Patient selection according to treatment tolerance is another criteria that we need to use and apply in clinical practice.
Right. Thank you for all your inputs, and thank you all my panelists. Over to you, Dr. Mohapatra.
Now, we'll like to invite Professor Akhil Kapoor, who is one of the from the TMH Banaras actually, one of the most premier institute and the part of the premier institute is Banaras actually. And he is actually very keen in lot of researches actually. Learn it, Professor Akhil Kapoor.
Yeah. Thank you, sir, and thank you to the entire team. Professor Carlos has given a very insightful discussions, and Dr. Jyoti ma'am made some finer points much clearer. And also, we expect an ESMO MCBS score of 4 for DB09 regimen. So I think ESMO MCBS score is one of the best possible scores, which, as a clinician, as a oncologist, we look at. So that I think the scores will be 4. QL data, if published in detail, I think this will. Professor Carlos, any comment on this point? ESMO MCBS score for DB09, though officially not announced, but
I don't know. I don't know the details of that, but I think it's going to be a high score.
yeah.
And I think that, as I just mentioned, Akhil, I think that there is a perception issue on the toxicity of the drug that we need to do revisit. Okay, both companies, AstraZeneca and Daiichi, have actually presented appropriately the drug with a lot of emphasis on some of the toxicities. Okay. But when you look at the results that we just saw, there is a group of patients that actually can tolerate the drug for a long period of time. Okay. So we need to consider that when we apply these results in our clinical practice.
Yeah, completely agree with you. And also, we have seen TDX being utilized in second line in our practice already for even for 30 cycles, 35 cycles, going beyond that also. So we have already seen
Exactly.
that already in our practice in second line. So why
Exactly.
not utilize
Exactly.
the best possible combination first line? This is what has happened across the treatment paradigm in oncology. Similarly, in ALK positive lung cancer, we used to discuss whether lorlatinib can be utilized in first line or not. It is a toxic drug, but now everybody has gradually shifted to the same because of its very good efficacy, and we have learned how to manage the toxicity. The same thing I am seeing that in next few months, I think all the oncologists will have more convention and they will be able to utilize this best possible combination. This is where we are heading as a oncology community. That is what I can understand. So let's touch upon some important points related to brain metastasis. I think most of these have been touched already, but I will focus specifically on the brain part so that we can have the analysis of the brain part. Otherwise, they are sometimes missed in discussions. So these are the current guidelines. Tuca Trust 2 plus CAPE is one of the preferred recommendations, but that was based on the trial because TDX trial initial trials did not include specifically brain metastasis, but now we have seen multiple data sets coming in where TDX is very useful, and we have seen that in our real world practice as well. So no doubt about it. So this is all the data, Emilia, Camilla trial data, then lapatinib data. Lapatinib is definitely a very less utilized nowadays whenever the drugs like TDX and trastuzumab combinations are feasible. And these all data sets have become a part of the history where the response rates were to the tune of 20 to 30%. Lapatinib was the first drug which showed some good response rate. Then came neratinib. Neratinib is not a very well tolerated drug and therefore not very much utilized in the practice presently. If we see the neratinib data, Nala trial showed median PF small improvement. We are, as a medical oncologist, we are used to see improvements of 2 months, 3 months in median PFS, and now we are suddenly seeing improvements in terms of years in terms of median PFS. So that is what is very heartening to understand and see the differences of just 2 months or 3 months, where most of the time our colleagues in tumor board can mock us that you are improving a treatment by 2 months, survival by 2 months. But here, thankfully, we are able to improve survivals by years, actually, 1.5 years. So that is what is important. So Again, this is hard to climb data, which we know it was definitely a decent data to start with. Again, not so much differentiated, 5.6 versus 7.8 months. So, but that is what we were used to see. But now we are seeing a lot important more data. This is hard to climb to data, specifically for brain metastasis. If we see data sets, tucatinib plus TDM1 doesn't make significant improvement. So TDM1 combined with tucatinib doesn't add much to the survivals, including PFS, though some improvements are there numerically, but it doesn't make much sense to use a combination which is toxic at the same time, not improving treatment outcomes in a very significant way. So if we see more data sets evolving, a combination of tucatinib plus trastuzumab plus par2 plus minus hormone therapy, this is the what we are looking at. There is some improvement in the outcomes. This is another approach which can be considered when the patient were started on the protocol, Cleopatra protocol, then tucatinib addition as a maintenance treatment. This is what the data has come up. But yes, what we understand and what we have seen, the miles, leaps and bounds improvement in the outcomes are by two regimens. One is Patina, one is DB09. So these two regimens have actually been very impactful, and we need to select between the two in hormone receptor positive patients. If it is hormone negative, there's no doubt and no differences. And we have also seen TDX plus per2 being doing equally good in patients with hormone receptor positive. So yes, we see the pooled analysis from multiple trials, DBO1, DBO2, and DBO3 trials. You will see the outcomes differences and improvements in patients with brain metastasis is substantial. It is beyond comparison. This is somewhat the data which we used to see for gefitinib versus osimertinib. Differences and outcomes are huge. You can see a large differences in the survival curves between the two arms, which is very, very different, including patients with brain metastasis. Hazard ratio with brain metastasis is 0.25 versus 0.3 with no brain metastasis. So quite similar hazard ratios. If we see the pool data sets again, if we see data sets, this is the combined data, and this is a very, very large data for pooled analysis, where we see that overall intracranial response is to the tune of 45 to 46% with TDX, which is as compared to the comparator arms, they are reaching just 12 to 25%. It is at least double of the intracranial responses with TDX data. So I think there's no doubt about it that TDX is doing very well in terms of controlling the brain metastasis. Is one of the very effective.
Dr. Akhil, you're on mute. You can unmute yourself.
Yeah, coming back to this CNS PFS data, which I was trying to highlight. Yes, the treated patients with are doing much better in terms of outcomes. And if we see the site of first progression per BICR, intracranial progression were 15% in comparator arm, and close to 20-25% are progressing in the brain. So again, even with good drugs, patients who are having brain metastasis, brain is a very important site of progression in 1/4 of the patients. So that we need to be careful, and we need to do proper evaluation of the brain during the treatment of the patients. And this is about the drug safety. I think we had a very insightful discussion, a very crisp comments already given by Professor Carlos about the drug tolerance, drug discontinuation rates, TDX. Now we are much more comfortable, and we have data of close to 200 patients under publication from our own institute and the second line and beyond settings. And now we have just started utilizing the first line setting. Hopefully, we'll come up with the data shortly published. So this is how we have come up And definitely the intracranial response rate with this drug is huge, and it is much better than any other comparator arms. And the response rates are to the tune of 50%, and median CNS PFS is also prolonged controls, which is what is important. So it is a very effective treatment option. Coming to DB12 data, this is again another single arm two cohort open label study of TDX in previously treated HER2 positive metastatic breast cancer with or without brain metastasis. This is one of the largest prospective data which is evolving, and we have seen this data sets of close to again 520 plus patients. So this again shows 12-month PFS of 60% overall population, and CNS PFS again 12-month CNS PFS reaching 60%, close to 60%. This is the responses durations, and we are clear that the responses are sustained for a longer time. And coming back to important points of ILD and ejection fraction decline, these are not much different, and it is how you investigate your patients, how quickly the patient can hint you about the toxicities. It is ILD reduction can be done if you are counseling the patient well. In our practice, we started to give a flyer to the patients and caregivers about the toxicity management and what to report early so that we can identify toxicity at grade 1 instead of being grade 2 and grade 3. That has helped us, and patients now report grade 1 ILD, grade 1 or grade 2 symptoms. Grade 2 symptoms are identified early so that we can reduce the chances of grade 3 ILDs in our practice. So yes, it is important to investigate properly, do a HRCT thorax after 2 cycles, especially the patients who have some amount of COPD and previous existing interstitial lung diseases. So to conclude, all these data sets clearly highlight the benefit of this very important drug, which is one of the best possible treatment options available in this subgroup of the patients for breast cancers. So yes, we need to learn and manage the toxicities, and our job as a medical oncologist is to make sure our patients receive the best possible treatment and we are able to manage the toxicities. It is not that we should be able to give the easiest treatment but not getting the expected outcome. So give the treatment which is specialized, best suited for your patients, and we need to utilize this more and more in our practice. With this, I would like to stop here. Thank you for the patient listening.
Thank you. I have a last question from Professor Carlos. Actually, what is your next line best treatment for somebody progressing in Destiny Breast 09?
Excuse me, can you repeat that? I'm sorry.
What is your best regimen if somebody progresses on trastuzumab deruxtecan in first line? What would be your second line best regimen?
Okay, I think that summarizing this very interesting discussion, thank you very much for the discussion period and the CNS presentation. I really enjoyed it. I think that you can easily say that with the results that we have available in a patient with metastatic HER2 positive disease that actually has no contraindication and can tolerate TDXT, I think that the regimen TDXT and pertuzumab so far is the best first-line alternative that we can indicate at the present time. We have other treatment alternatives, and we need to address the fact that maintenance treatment seems to be an important part of this treatment that we need to integrate with this first-line alternative. So I think that we need a lot to learn. But if we have to select a first-line alternative in a patient that can tolerate it, and as long as the patient can tolerate it, I think that TDXT with pertuzumab would be my first choice.
Any after progression on TDXT and pertuzumab, what will be your second choice?
If a patient has a progression on TDXT and pertuzumab, we don't have formal data. in order to make intelligent decisions in this regard. We have some evidence, and there is some publications coming out suggesting that expert opinions in this regard are all over the place. You can use double blockade, you can use TDM1, you can use triple blockade as a possibility. Remember, I mentioned the complexity of these pathways and the fact that we know that blocking one receptor or one receptor in two different places or blocking the pathway in three different places actually makes a difference from the clinical point of view. So I think that in a progressing patient, this may be a consideration. So there are a number of different treatment alternatives in second line that we do not have definitive answer for. So I think that at the present time, I would tell you that I will tailor this according to what the patient actually may be presenting with. If it is a very rapidly progressing patient, maybe using double blockade or triple blockade, quote unquote, kind of a HER2 climb kind of regimen with chemotherapy would be an interesting approach. But this is something that we need to develop further, and we don't have definitive answers as of yet.
Thank you, sir. Thank you. It's already time, and thank you for your excellent presentation, and thank you, Professor Akhil Kapoor, for his excellent presentation, and Madam Jyoti Wadhwa for our excellent moderation as usual, and all the panelists. I think it's over from my side to the organizers.